Good morning, everyone. I'm delighted to be here today. It's a very important subject. It's a very unique one. Why do we love health economics? You can talk about money without ever having to make any. Mick Jagger and Arnold Schwarzenegger both studied economics, and look how they turned out. Economists are armed and dangerous. Watch out for our invisible hands. Okay, so today we're going to go over the opportunities and the challenges to using health economics to study genomics. And I'm going to give you some of the research we've been doing at our center and both work we've already done and work we're doing now. I think there are three major ways to think about why we're having this meeting today. First of all, how do we conceptualize the value of these new technologies? Secondly, how do we obtain data and conduct analyses? And then thirdly, how do we consider value within that broader social and political context? So they always say to make your most important points, and then I can just sit down because I'm done. Just kidding. But here's the summary of what I'm going to say. If you don't listen beyond now, you've gotten the gist. It's complicated. It's complicated in all countries. Someone needs to do it. Some of our approaches we've been doing have worked, and some have failed miserably, but we're still trying. Challenges are global. We've been writing a book chapter with Kathryn on economics of genetic testing. I do a lot of work for Canada that's doing a lot of work in genomics. Most recently, I went to the Middle East. They've bought a lot of sequencing machines, and they're intending to sequence their entire population, and they have a lot of money to do it. And I've done various work over the years in Europe. So we have a study funded by the National Institutes of Health on the benefit-risk trade-offs for genomic sequencing. This is a 4-year study, a couple $1 million. It has 3 major components: a stated preferences study, a study on coverage and reimbursement policies, and then finally the study of economic value, which is what I'm going to cover today. So first of all, how do we conceptualize? Here's the strobe lights, I think, where, you've got to put on the thinking cap because this is very complicated. I've been in this field for over 20 years, and genomics is the most complicated area I've ever studied as a health economist. So first of all, just to be sure we're all on the same page as to thinking about what is it we're even talking about and how can we define our terms. If you think of genetic testing as being a continuum, where historically we've done single gene testing, we're moving to gene panels with multiple genes, you can have whole exome sequencing, and then finally whole genome sequencing. And within this continuum, you can think of the difference between inherited and germline testing versus acquired or somatic testing. And you can think about disease-specific testing, such as for cancer, versus general genomic medicine, which is when you would test a population without any specific risks. In other words, sequencing is not sequencing is not sequencing. We tend to use the word sequencing, but it can mean a lot of different things. For example, you could be sequencing tumors for immediate treatment decisions using established gene panels to look for variants with known clinical utility. That is very different from sequencing in a general population. Look for any variants that may be predictive of future risk, regardless of the lack of any known utility for those variants. 2 extremely different uses, but they're both called sequencing. I also find it useful to think about a conceptual framework because everything's a trade-off, right? I'm an economist. Everything is a trade-off. So you have trade-offs between the benefits and the risks. So first of all, you can think about who gets sequenced and why, how is the sequencing, the testing actually done, and what results are obtained and how they're used. And then you can think about doing studies and looking at issues related to preference in the use of tests, adoption and reimbursement by payers, and the economic value. Another way to think about it, this was published in Health Affairs, where we laid out a conceptual framework for policymakers so that they could get their arms around these new genomic technologies. So if you think of sequencing as being a series of the inputs, the methods used, and then the outputs. And under each of those, you have differences in how the testing is done. And that's going to impact your policy implications. And as has already been alluded to, there are all the issues about the fact that we get a lot of findings when we do whole genome sequencing that we don't know what they mean. Either they're not directly clinically actionable, or they are of unknown or no clinical significance. The estimates I've heard is that if you're testing in a general population, about 1% to 2% of people will actually get a clinically actionable finding based on what we know now. So you can have a lot of findings that are in this gray zone. And of course, those could all lead to decisions about how to treat the patient and then a series of outcomes. There are a lot of complexities in doing economic analyses of sequencing or any of these new genomic technologies. You can't just do a simple test versus no test because the complexity is overwhelming. There are too many clinical pathways involved when you have multiple findings. You have interactive effects between findings. You have the issue of non-monetary risks and benefits, such as personal utility of just knowing. You have the potential disutility of findings for future risk that you may not want to know or that may occur way into the future. I was talking to Michael Rollins, former head of NICE, and he was saying, I wouldn't want to know if I have a risk for something in the future. Why no? And I'm like, I would want to know. So people vary as to their personal utility. More complexities, and there are a lot of different inputs into the cost and the outcomes that are going to vary depending on what you're looking at. And you need to consider how you're going to allocate and aggregate the cost and benefits of multiple findings. That sequencing will not be equally cost effective across various uses. And as always, we're mostly interested in the comparison to current methods of detection as opposed to nothing. We're currently writing a solicited paper for pharmacoeconomics where we're going to solve all these issues, in the next month or two. Okay, second topic. How do we obtain data and conduct analyses? Here's where the rubber meets the road. You can think about it. We've been thinking about it for a couple years now, but now it's time to actually do it. Well, there aren't many people actually yet doing these analyses. Here are some of the questions that you might want to be studying. Some people have started studying. Maybe there are people in the room who are doing this, hopefully. What do we currently know about the cost and outcomes of these different mutations that we might find? How will these new technologies change the value equation? Are they substitutes for existing testing? Or are they additions? Where are the new technologies most effective and efficient? How can the different uses of testing be prioritized? In other words, not anytime in the near future are we going to sequence everyone at birth and that's the end of it. That there's going to be still a place for single gene testing, and we have to figure out where and when to use these technologies. How does cost effectiveness vary if sequencing is used in a targeted versus a general population? And what is a break-even point? We're looking at this in terms of panels, because panels are getting so cheap that it's cheaper to do a panel so that includes BRCA as opposed to only doing BRCA. So then you have a break-even point at which you might as well do a panel instead of doing the single gene test. So where are we going to get the data? Well, there are lots of different sources, none of which are perfect. Obviously, the literature, There are various observational data sources, electronic health records. Although a major problem with our EHR in the US is they don't include the test results. Whoops, no test results? No, they don't include the test results because test results come back in a PDF file from the lab, and that can't be directly input into the EHR. You have various registries all over the world. You have claims databases. You can draw from existing models and analyses, as I'll describe a study by Bennett in a minute. That's what they did. You have prospective data collection with randomized clinical trials. And a number of these are being funded in the US. I've been working with the MedSeq trial that's being done at Harvard, where they're randomizing general population to whole genome sequencing or not. There are a number of different approaches, economic valuation approaches. We often focus on cost effectiveness analysis, but there are actually a lot of different approaches that could be of use here. Evidence synthesis, simulations using existing data and models, budget impact models. I've been working with a group that's doing a budget impact analysis, and I think that's actually going to have a lot of importance. Cost effectiveness, as we talked about, preferences, willingness to pay, as we've been doing. By the way, that's extraordinarily difficult in this arena, but we're trying. Multi-criteria decision analysis, value of information analysis, and what I call social actionability. So here's some examples of some of the studies that I'm aware of or that could be done. For example, MedSeq is doing economic analysis alongside their clinical trial. I already mentioned the budget impact study. What we call the Uber model of whole genome sequencing in a general population. I don't know of anyone doing this. Maybe you guys have figured it out. But people say, well, what we need is one huge model where we say you're sequenced or not, and here is what would happen if you get sequenced. But that would be the biggest model I've ever seen in my life. So we decided not to do it, but you guys are so on top of things. I'm sure you guys can figure it out. Social actionability, as I mentioned, just the issues of implementation. Is there a test for what we're looking for? Is it equal access? For example, in the US, if you're poor, you still don't get genetic testing in the same way that you do if you're rich. Most of the people getting sequencing now get it because they pay out of pocket. They can afford it. Not many people can. And does the test provide good value? So we have recently done a evidence synthesis study to look at the cost effectiveness of returning secondary findings. The ACMG came out with a recommendation, you've probably heard of it, where they said these are the 56 genes that if you're doing whole genome sequencing should be returned to patients because they're clinically actionable. Well, but no one has looked at whether they're economically of value. So we did a search to see what is in the literature about these 56 genes. Well, fewer than a third of the conditions in the recommendations even had any economic analyses at all. And less than 10% of the studies actually examined cost effectiveness in a general population, as would occur in a study of whole genome sequencing. So basically, we don't know much about the economic value of returning those findings to people. Here's a study that was done by Bennett. It was published in Genetics and Medicine. We have a letter coming out in response. It's a great study, but we think they had some things that they might have expanded on. So we wrote a nice letter about how they might have done that. It was actually a very creative approach because they wanted to look at what is the cost effectiveness of returning secondary findings, not of whole genome sequencing per se, but of actually returning findings. So they took existing models, took the cost and quality data from those models, multiplied that times the expected prevalence in a general population, and then added it all up. Okay, well that's creative. But there were a couple things that they did that we thought in the next study should be expanded on. One is that they assumed that people who were at risk for these conditions would never be detected in their entire life through any other means. So sequencing got all the benefits given to the sequencing test. We thought they should have included the background rate of detection, because you never compare something to nothing. You always compare it to what would have occurred otherwise. They aggregated all these different studies that have been done in different ways with different methods by different groups into one overall ratio. We could not replicate their results. So in the future, it'd be good to have something where everyone could do the same thing. And then they didn't consider interactive effects or potentially negative implications. They only considered positive benefits. Okay, speaking of the 1,000 genome, yeah, I've seen that chart so many times, but you know, sequencing is not $1,000. That's the price of the test. That is not actually a good reflection of the true cost of sequencing. So we wrote a paper that just came out that looked at that issue of what is the true cost of sequencing and how cost effectiveness will vary. So we did some simulations. We had a Lynch syndrome model that we had used before. So we did some simulations, and this is a simulation if you were doing sequencing for Lynch syndrome in colorectal cancer patients. That was a targeted population. And as you see by that big blue line at the top, this is looking at incremental findings. And if your incremental findings are of no proven benefit and costly, you can see that the cost per quality skyrockets very, very quickly, even if you only find one or two of those types of findings. This is our results looking for Lynch syndrome in a general population, in other words, a population without risk. And you see that the cost skyrockets even quicker. So that's a major point of those simulations. So finally, how to consider the larger context. You may have read about the White House initiative to put a lot of money into developing a longitudinal research cohort of 1 million people who would get sequencing, among other things. And there's a lot of interest in this. There have been papers in the New England Journal of Medicine, but I've read through all of the materials, and there's actually not much consideration of the healthcare delivery and economic issues. It's all about, well, we're going to get all these people, and we're going to get tons of data from them. They're going to be having wearables and sensors and smartphones, and we're going to get their microbiome, and we're going to aggregate all this data. And it's like, well, then what? Oh, well, something good's going to happen. Well, okay. Well, but it'll keep us busy for a long time. The Patient-Centered Outcomes Research Institute in the U.S., I just met with their director, and I'm going to be working with them to develop a research agenda in personalized medicine. They're very interested in funding work in this area. PCORI, it turns out, has more funds than NICE in the UK. It's the largest comparative effectiveness research funder in the world. So they're putting a lot of money into this. Implications, all of what we've been talking about today is part of big data and the trend towards big data, which is a very big trend. And how do we connect all these different data elements? And I think major issues going forward are how to prioritize both the studies that we're doing, how to prioritize the return of findings, and how do we consider economic value.